Thank you very much, everyone, for coming. And let's start. Dr. Hussnain, you want to start, and then Anna will start presentation.
All right. Thank you very much, Dr. Sajad, for giving us this opportunity to present a very controversial, probably the most controversial topic in clinical neonatology. I think it's the wrong question whether PDA should be treated or not, but we'll take a deep dive before we start talking about the details. So I want to ask Dr. Anum Shah to start the presentation. We will be presenting a consensus report that was published by the American Academy of Pediatrics just about 3 months ago. So let's take a look at it. Anum, you go.
Dr. Anum Shah, yes, please.
Assalamu alaikum, and thank you for joining the Journal Club. I'm Dr. Anum Shah, a neonatology fellow at PAF Hospital, Islamabad. This presentation was prepared under the kind supervision of Dr. Mirza. He is Neonatology Fellowship Director in Orlando, Florida. And to be particular, this is not an original article, but a consensus report that the American Academy of Pediatrics has published in May 2025. There is no hypothesis testing here, but article is important because PDA management is a very controversial subject in clinical neonatology. This article was approved by the fetus and the newborn committee and cardiology and cardiac surgery section of the American Academy of Pediatrics. So how common is PDA? It is definitely not a significant problem in term infants, but the prevalence goes up with lower gestation. As you can see this table that I charted out, as the gestation decreases, the spontaneous closure rates also decline. More than 80% of infants born at or less than 24 weeks may have a PDA which persists beyond 7 days of life. So then again, the question of whether to treat or not treat PDA. Treatment of PDA in preterm infants is an important question because there is a very strong association between PDA and poor clinical outcomes like IVH, periventricular leukomalacia, cerebral palsy, necrotizing enterocolitis, prolonged need for supplemental oxygen or mechanical ventilation that increases the risk of retinopathy of prematurity and bronchopulmonary dysplasia. So mortality is also higher among the preterm infants with PDA. However, multiple studies also showed no benefits of PDA treatment in terms of all these poor clinical outcomes. So why do we need to treat PDAs, and why do we need to take the additional risk of medical or surgical treatment? So there was a study. I am sure you all have gone through the article. It was a Tolerate PDA study. This was conducted for infants born at 26 to 31 weeks. So in different clinical trials favoring late or no medical treatment, 90% of preterm infants born between 26 to 31 weeks had spontaneous closure by 36 weeks corrected gestation. For those discharged home with PDA, 50% will spontaneously close by 49 weeks corrected gestation, and 80% will spontaneously close by 2 years of age. So if most PDAs will close spontaneously over a period of time and PDA treatment does not improve clinical outcomes, what is the benefit of PDA treatment? So here are two plausible explanations for the lack of treatment benefits. If PDA is a morbidity of prematurity like IVH, necrotizing enterocolitis, and bronchopulmonary dysplasia, its treatment will not improve other outcomes since there is no cause and effective relationship. However, in multiple studies, results were adjusted for gestation and PDA was independently associated with poor clinical outcomes. Second possibility is a potential flaw in the study designs, showing no benefits of PDA treatment. Most important deficiency is the lack of PDA profiling. Most studies accept PDA as a categorical variable that means yes or no PDA, regardless of the hemodynamic status or impact. And many studies also allow a crossover for infants in control group if they meet certain criteria for treatment. Success and timing of PDA treatment will also impact the clinical outcomes. For example, if treatment was offered after 1 week of life, we shall not expect improvement in IVH because that has already happened. So as this diagram is self-representatory, so in the last 2 decades, there are 2 major changes in PDA management. First change is in the medical treatment of the ductus. A few years back, all PDAs were subjected to treatment. By 2012, it was realized that PDA does not need treatment and it does not affect any clinical outcomes. So clinical practice flipped in favor of tolerate PDA. This is an ongoing debate and both sides have strong arguments. Perhaps both extremes are outdated and misplaced concepts, and balance is somewhere in the middle. Clinical fraternity is still trying to develop an objective criteria for the PDA treatment. Second change is transition from surgical ligation to device closure. As more institutions are adopting device closure, surgical ligations are phasing out. FDA approved Piccolo device in 2019 for infants more than 700 grams. In some US centers, new threshold for device closure is 500 grams, and some centers are offering bedside device closure. However, primary question on PDA treatment is not clearly answered yet. We do not know the criteria and timing to recommend PDA treatment. I'm going to move on to the assessment of hemodynamic significance of PDA. To better understand the confusion about PDA management, it is very important to objectively define the criteria for hemodynamically significant PDA. Today, there is no standard definition for HSPDA. Assessment of HSPDA in preterm infants involves evaluating the extent to which the PDA affects the cardiovascular physiology and contributes to clinical stability or instability. So the key aspects include, number 1, echocardiographic findings, clinical indicators, and then laboratory assessments. This is a very important slide and a very important figure. So a simple echo report of a small, moderate, or large PDA is not good enough anymore. So we need to be objecting it more and profiling it more. So this illustration provides a general approach for objective profiling of PDA, relying on several measurable parameters. Number 1 is the ductal shunt size. It is estimated by analyzing the diameter of the ductus and the flow pattern through it. Number 2 is volume overload. It is assessed by the LA to AO ratio, which is the left atrium to aortic ratio and left ventricular output, indicating the degree of volume returning to the left side of the heart. Then there is pulmonary overloading, number 3, which is evaluated using the LA-AO ratio, the left ventricular output, and the left pulmonary artery, reflecting excess pulmonary blood flow. And number 4 is systemic hypoperfusion, which is determined by measuring the flow in the descending aorta and in the arteries supplying the organs, specifically the brain through the cerebral arteries, the kidneys through the renal arteries, the GIT through the splanchnic, indicating compromised blood flow. So clinical indicators are simple: signs of volume overload, pulmonary overcirculation, and systemic hypoperfusion. So after echocardiographic profiling, we have to pay attention to the clinical indicators. So for volume overload, we look at widened pulse pressure, tachycardia, which are non-specific. Number 2 is pulmonary overcirculation, which could be indicated by respiratory instability, increased oxygen requirements, radiographic evidence of pulmonary edema, and then systemic hypoperfusion by hypotension, decreased urinary output, or renal impairment. Some non-specific laboratory assessments. These 2 tests are described for objective evaluation of volume overload. There is no clinical trial, however, to use these markers for PDA treatment, but these blood tests can be considered for serial monitoring or evaluation of volume overload. This is a suggested definition, and this is probably the most important table in this article if you've all gone through it. They have proposed a new definition of HSPDA based on a modified PDA scoring that was originally published by Patrick McNamara in 2007. Original scoring system was hard to adopt in clinical practice, so they are using the simplified version. However, even in this modified system, clinical criteria are very vague and subjective. For example, there is no definition for high CPAP or FiO2. So what is the qualifying criteria for renal dysfunction? What is the definition of abdominal distension, feeding intolerance, or poor growth? Similarly, in echo section, no definition of moderate or LA or LV enlargement. So I doubt the system can be successfully adopted in clinical practice. However, a practical objective definition for HSPDA is essential to resolve the conflict on PDA treatment. Moving on to the prophylactic therapies. Prophylactic interventions, which are medical treatments administered without confirming the presence of PDA. So prophylactic treatments such as NSAIDs or other pharmacological agents usually are not recommended because current evidence shows there is no improvement or mortality in BPD or neurodevelopment impairment. We could have early fluid restriction. It may reduce the incidence of PDA, but also this evidence is based on very old studies. Routine early treatment within first 7 to 14 days to induce PDA closure, regardless of whether it is HS, does not close the duct, does close the duct, but does not translate into improved clinical outcomes, and thus it is not recommended. So in conclusion, this article does not recommend prophylactic treatment for preterm or very low birth weight infants. Moving on to the pharmacological therapy for symptomatic PDA. Pharmacological therapy for symptomatic PDA in preterm infants is considered when the PDA is, again, hemodynamically significant, as I mentioned earlier, and clinical intervention is warranted. So preferred timing for pharmacological closure is beyond 2 weeks of age, and all three choices that I've mentioned here, including which are prostaglandin inhibitor drugs, ibuprofen, indomethacin, and acetaminophen. So all three choices are available, but ibuprofen is more popular for better safety profile. So a little detail about ibuprofen. First-line agents include ibuprofen, this is a preferable pharmacological agent for inducing ductal closure. It can be used after failed initial measurements or when indications suggest that continued medical management is appropriate. Dosing typically involves multiple courses of the PDA. Persist through exact dosing regimen can vary based on clinical protocols. While it is generally effective, ibuprofen has a favorable safety profile in most preterm infants, but clinicians opting for this modality should monitor for potential adverse effects such as renal impairment or GI complications as well. Alternatives such as acetaminophen and indomethacin are acceptable options when ibuprofen is contraindicated. According to the statement, up to 2 courses of medical therapy can be considered. A little on expectant management. Expectant or conservative therapy for PDA involves careful observation and supportive management without immediate medical or surgical intervention. This approach focuses on optimizing the fluid and electrolyte and nutrition status while supporting the cardiovascular and respiratory systems impacted by the PDA. So the strategies in expectant management include fluid restriction, diuresis, and number 3 adjustments to vent settings. They may need higher end expiratory pressures and permissive hypocapnia to minimize the hemodynamic impact. This conservative management, if often chosen in cases where PDA is hemodynamically significant or when the risks of intervention outweigh the potential benefits. Ongoing research continues to evaluate the optimal timing on criteria for choosing expectant management versus active intervention, with some data suggesting that many PDAs close spontaneously, especially in less symptomatic infants. Moving on to surgical closure. So surgical closure of PDA involves ligation or division of the ductus to eliminate the abnormal shunting. According to this article, surgical ligation is typically considered when pharmacological therapy has failed or is contraindicated, specifically in infants with an HSPDA beyond 2 weeks of age. Some comparative studies showed that surgically closed infants tend to be younger and more premature with higher support needed prior to surgery. Surgical ligation has been associated with shorter procedural times, but then again involves higher morbidity related to the invasive intervention, longer hospital stays, and extended periods of mechanical ventilation. In addition, infants who undergo surgical ligation have been found to be more likely to develop BPD, ROP, and neurodevelopmental impairment. Recent trends indicate a decline in surgical ligation rates as transcatheter approaches have become more prevalent, but remains an essential option when less invasive methods are unavailable or ineffective. Surgery is typically reserved for cases where medical or transcatheter methods are contraindicated, unsuccessful, or not feasible. There are some complications of surgical closure, including pneumothorax, wound infections, paresis of the left vocal cord or diaphragm, chylothorax, and risk of scoliosis in later life. So, the use of transcatheter closure. It is a minimally invasive procedure that involves deploying a device to occlude the ductus arteriosus. Advances in catheter-based techniques, such as use of the Piccolo occluder, have made an increasingly viable option, particularly for preterm infants weighing as little as 700 grams. I added this picture to show how minute this occluder is. So studies have demonstrated that transcatheter closure can be effective with fewer days of mechanical ventilation and possibly better outcomes related to shorter hospital stays, especially in comparison to surgical ligation. This procedure involves inserting a catheter via the femoral vein to deliver an occlusion device under echocardiographic and fluoroscopic guidance. So the occluder's size and shape is designed to fit the ductus of a premature infant. However, like all procedures, transcatheter closure does carry its own risks, including device embolization, device malposition. There are some rare instances of respiratory arrest and other procedural complications. Overall, outcomes depend on patient selection, timing, and experience of the center. Although safety and efficacy have improved, ongoing research, such as the pivotal trial, which aims to better define the long-term benefits of transcatheter closure. So this statement that we've gone through, the statement highlights several important opportunities for clinical trials related to PDA management in preterm infants. So the key research areas that are still to be discovered include establishing the relationship between measures of hemodynamically significance of PDA and the risk of adverse outcomes such as BPD, pulmonary hypertension, and neurodevelopmental impairment. This involves identification of optimal timings and methods for achieving ductal closure through well-studied designs. Number two is conducting meticulously planned intervention trials that evaluate not only short-term physiological endpoints like ductal closure, but also long-term clinical outcomes, including neurodevelopmental and respiratory health. Such trials should have clearly defined treatment protocols to ensure reproducibility and enable comparison across studies. Number three, determining whether closure via medical, surgical, or transcatheter methods truly prevents adverse outcomes associated originally with the PDA. This involves long-term follow-up with neurodevelopmental assessments to validate the causality between ductal patency and developmental impairments. Number four is improving the understanding of the efficacy, safety, and long-term benefits of transcatheter closure techniques, as this approach is gaining increasing acceptance. In summary, this statement gives us 6 recommendations for clinical practice. Number one is prophylactic medical interventions not guided by PDA status and are not recommended at any age or birth weight for preventing symptomatic PDA, as they do not impact mortality, BPD, or neurodevelopmental outcomes. Number two, early fluid restriction may reduce the incidence of PDA. However, this evidence is based on historic studies and new data are not available. Number three, use of diuretics may be useful to minimize the hemodynamic impact of PDA, but it also increases the prostaglandin levels, which reduce the chances of spontaneous closures of PDA. Number 4, routine early treatment within the first 72 hours or up to 14 days, whether medical, surgical, or transcatheter, to induce PDA closure, irrespective of hemodynamic significance, is not recommended because it does not improve outcomes and may cause unnecessary risks. Number 5, observation and supportive management are preferred initially, with intervention reserved for cases where PDA remains hemodynamically significant and associated with adverse outcomes or complications. Lastly, infants with HSPDA beyond 2 weeks could be given a trial of pharmacological closure, ibuprofen preferable. And lastly, infants with HSPDA beyond 2 weeks of age, despite up to 2 courses of medical therapy, can be considered for transcatheter or surgical closure. Thank you so much for listening. Overall, the article advocates for a cautious evidence-informed approach that prioritizes supportive care and reserves invasive procedures for selected cases with continued research needed to clarify long-term outcomes and refine management strategies. Thank you all for listening.
Thank you very much, Dr. Anum. It was a very good presentation, and thank you to Dr. Hussnain for supporting you and supervising you. So we're going to open the floor for questions. Hussnain, can I ask one question?
Sure, sir.
Yeah. In one of your slides, you mentioned about the management, and you said oral ibuprofen in larger doses is recommended. Is this the first line of treatment? And if it is, then what is the larger dose which is recommended in this article?
So it's 10 milligram per kilo per dose rather than 5 per kilo per dose. That's the difference between larger dose and standard dose.
But the standard is also first dose is 10 milligram per kilogram, and second and third are 5 milligram per kilogram.
Yes. So the higher dose people use just 10 milligram per kilogram.
So are you saying that all 3 doses should be 10 milligram?
No, I'm not saying, sir, that
yeah, from the article, yeah.
Yes, they are suggesting to use higher dose, and that higher dose is 10, 5, and 5.
Yeah, which is actually standard dose.
Yeah, because some units are using 5, 5, and 5.
Yeah, but there have also been studies which people have tried to use 20 and 10 and 10, comparing with the 10, 5, and 5. Okay, thank you very much. The floor is open for questions and discussion. And any comments from the seniors?
Naila has one question. Naila, Dr. Sajjad, Naila hand raise.
Assalamu
Dr.
alaikum.
Naila? Yes, wa alaikum salam. Yes. Dr. Naila, yes, please.
I have a comment and a question. Anam, I really liked the presentation, the way you were speaking. You just asked me to involve. I was busy in something else, but I just put all my attention towards your presentation because you were presenting very lively and very good. I just like the way you have made your slides. And my question is about the timing that we should not treat in first 2 weeks, because in my clinical experience, most of the time the presentation is in the first week in which the baby gives all the sign and symptoms. So I'm just confused why this 2 weeks window is given.
Because,
can you
madam,
hear me?
Yes, ma'am, I can. Because most infants, most PDAs close spontaneously by 2 weeks. So I think they should be given the benefit to have a spontaneous closure rather than inducing them with medications that have their own side effects.
Dr. Sajjad, just to add on this point, not only that, Naila, the 2 weeks, many studies, especially the latest study done in 28 to 23 weeks. So these patients are already very sick. There are many other conditions and many other signs and symptoms and many other pathology going on. Now, the PDA, most of the, as Anam said, is closed by 14 days. So if you treat 7 days or early, then the chances of mortality is high in those patients of the treatment. This is a harmful. If you see this article, if you go through the key concept and it is written there, so the harmful effect is there. So after 2 weeks, if the baby is still not improving and this thing, then I think it is better to look into it. But I think Dr. Sajjad can correct me, or Hussnain, very rarely nowadays we are treating.
Thank
The
you.
number of ducts which we treat these days is significantly reduced.
Yeah.
Yes, Hasnan. Sorry.
So just to continue, what Dr. Junaid was saying, actually this PDA management got so much confusing because all the studies that were done on the PDA, I think the study design is inadequate for 3 reasons. One is that everybody is looking at PDA as a categorical variable. So PDA yes and PDA no, without any profiling. So every PDA is not same. A 2 millimeter size PDA in a 32-week baby is not the same as a 2 millimeter size PDA in 22 or 23-week baby, where it's going to cause a lot more damage. The second thing was the timing of the treatment and the success of treatment. So whether the baby was treated at 3 days of life, or at 7 days of life, or at 14 days of life, that variable was not included in data analysis. And the success of treatment as well. So in all these studies, the 2 groups are based on treatment groups or no treatment groups, rather than PDA treated or untreated. And they also allow crossover between the 2 groups when the babies in the control group.
Hasnan, can you please adjust your mic? Hasnan?
My mic.
Yes. Yeah.
No, it's not my mic.
Oh, no, that's better. That's better now.
No, it's not my mic. Okay.
So whatever was, but it's now corrected. Yeah,
Yes,
please go ahead.
Anyway. So when the babies, they cross over from control group to a treatment group, and that's just confusing. And the third thing is, people are trying to correlate the benefits of PDA treatment by looking at the outcomes like IVA, NET, or BPD. I think the highest risk of that is in the first 24 hours, not the 72 hours. If the PDA is treated at 1 week of life, I should not expect that the IVS will improve by the PDA treatment. So it's all very confusing, but the data out there is that as you leave PDA untreated, especially a significant PDA, after 2 weeks, the outcomes are really bad in terms of BPD and death. And that's the basis for the recommendation in the AAP article to treat significant PDAs after 2 weeks.
Thank you very much, Dr. Hasnan. Dr. Duresh Shahwar has a question. Dr. Duresh Shahwar.
Thank you so much, sir. First of all, Anam, thank you so much for bringing a very important topic in discussion. I have a comment and a related question. Number one, I agree with all the treatment options discussed here, including no use of prophylactic treatment, higher doses of ibuprofen, and the surgical versus transcatheter closure. So all were good points, but my confusion is about, you said that irrespective of the status of hemodynamics, The PDA should not be treated in early treatment should not be provided. Early means after 7 days to 14 days. That is a gray zone, because usually before 7 days, PDA is not usually a problem. And after 14 days, treatments are advised in most of the studies. 7 to 14 days is usually a gray zone for neonatologists. And most of us are exactly not treating the PDA on the size or other things, but because of pulmonary overflooding or systemic hypoperfusion, specifically neck. So kindly any senior can put light on it, that even in case of HSPDA, having HSPDA and any effect on systemic hypoperfusion or pulmonary flooding, is this really possible that we do not HSPDA even with early treatment? Thank you.
I can add into that. This is the same question that Naila asked actually. The early treatment, even for HSPDA, how you know that this is the hemodynamic significant PDA at the 14th day of life or before that, or at 7 days of life? That's the dilemma. The dynamics of echocardiographic, based on the thing that it is a component of PDA affecting the lungs, or it is a component of the other disease which the baby has, is the main culprits. So this is actually recommendation is based on in a very small babies. I am coming back to that point, which is less than 28 weeks to 23 weeks. That those babies, even it's clinically HSPDA, it is better not to treat, wait for 14 days. A similar thing, if you check the way and balance between the two, that which one you have to treat. A long time ago, Dr. Sajjad invited me in his conference in Saudi Arabia, and I presented with the same thing. So at that time also we have. Now, if you are more interested into this topic, read the Oscar Baby trial by Samir Gupta. He's so very good trial in a very small babies, and he also figured it out that the treating early is a harmful rather than beneficial. Hope I answer your question. Dr. Sajjad or anybody else can add it.
I think that's very good. Thank you very much, Dr. Junaid.
Thank you, sir.
I think yes, you're okay, Dr. Durashawar?
Quite okay, sir.
Yes,
Thank
okay.
you.
Dr. Saima Pirzada from Canada has a question. Saima?
Hi, thank you very much. Thank you, Anum and Hussnain, for presenting this topic very nicely. I just have a question, not on the duration, when to treat, when not to treat. I just want to know if we have decided to treat with preterm baby with feed intolerance. Still, ibuprofen will be our first choice in higher doses. And if baby fails and we need another course, will we go for ibuprofen again, or could we go to other option as well? Thank you.
Maybe Dr. Anum or Dr. Hussnain can answer this question.
So this question is like, it's mostly the local practice guidelines. We used to rely on indomethacin until, I want to say, until 5-7 years ago, and then we started stepping away from it. Now we want to use ibuprofen, and we use up to 2 courses, and we use higher dose if the standard dose does not work. Tylenol is another choice. My experience with that is that the treatment success rate with Tylenol is less than what I would expect with ibuprofen, but we use Tylenol as the second line medicine if ibuprofen, there is any contraindication. I will rarely use indomethacin. I'm not sure if people are still using indomethacin, but my experience
we stopped using indomethacin long time ago.
Yeah, it's not that many people are using it anymore.
Yes, please. Thank you very much, Dr. Hussnain. Any other seniors have any comments on this question from Dr. Saima?
I think now many studies came out already about the acetaminophen. We are using acetaminophen since I presented to you, Dr. Sajjad. in your conference, and we have a very good results. And this again, I refer to one of the study which is recently done. The results are not published, and they said that there is no difference between ibuprofen in any form, IV or oral, versus the acetaminophen, and the side effect is much lesser, and it is same as like a placebo. So we are using it again, as Hussnain said, it is the particular unit protocol. We started with acetaminophen, and if it is not closed, we give the trial of ibuprofen, but mostly it is successful. I think I presented in the hot topics also. I forget my own data, but anyway.
Okay, thank you very much, Dr. Junaid. Professor Talal Wakar had the question. Jana Saab.
Yeah, thank you. No, not Jana, sir. The
Welcome,
only
sir.
thing is that, thank you very much. The thing is that if you treat late, if you treat it after 2 weeks or so, doesn't the sensitivity of duct changes from prostaglandin to nitric oxide, and the failure of treatment is far greater? Now that's the problem of treating it later on. And the second thing is that regarding paracetamol and ibuprofen, the problem is that in a country like Pakistan, where we have overwhelming sepsis, your babies are septic. And with sepsis and gram-negative sepsis, we have low platelet count also. And so we prefer using paracetamol as compared to ibuprofen, which ibuprofen further lowers the platelet count. And so that is the reason that we are using paracetamol a lot more than ibuprofen. Just these two comments. Thank you.
Yeah, thank you very much, Professor Talal. Dr. Fowler had a question. Are you there, Dr. Fowler?
Can I just add one more comment in continuation of Dr. Talal's comment? Dr. Talal, I just want to say that the AAP recommendation to treat after 2 weeks is just a recommendation, is not really a evidence-based study. So if there is a baby who qualifies for treatment, you don't really have to wait for 2 weeks if you see a compelling reason to treat. There is nobody stopping any treatment before 2 weeks of life. It's just
Fair
a
enough. Absolutely. Fair
general
enough.
thing.
Is Dr. Fowler there? Are you
Yes,
have a question?
I just had a comment on a very nice presentation. I wanted to just say, and Dr. Mirza already answered me in the chat, is I work in Parkland Hospital here in Dallas, and device closure, even for the pivotal trial, as we are one of the sites, was as per our cardiology colleague, because they told us that they are not because of the weight cut off that they use here in Children's Dallas, which is 700 grams. So majority of our micropremies, and we do take care of a lot of micropremies because of the Parkland Hospital. We usually just do the conservative. Majority of our babies actually do fine with that conservative.
Thank you very much, Dr. Howard, for your comment. And please join our academic neonatology group. Dr. Ubaid Rahman, there's a question. Are you there, Dr. Ubaid Rahman? He's asking, if we are not treating before 2 weeks, is it logical to do echo in first 2 weeks? Maybe
So-
Dr. Anum or Dr. Hussnain can answer it.
So I think closing the eyes does not make a problem disappear. If you are clinically worried, do an echo. Nobody is stopping you to treat a PDA before 2 weeks if there is a compelling reason. It's a general guideline to wait until 2 weeks, but if there is a clinical indication and you feel like doing an echo will give you a valuable data, and you may have to treat a PDA sooner rather than later, I will do that. I'll give you an example. I just took care of a baby last week who was born at 25 weeks, started having pulmonary hemorrhage. And the people just want to keep higher and higher PEEP, trying to stop that pulmonary hemorrhage without looking why the baby has the hemorrhage. It's a 25-week baby weighing only 750 grams, and the PDA size was 4 millimeter with a significant volume overload. And That was the baby I thought needs treatment for PDA right away, because otherwise the pulmonary overcirculation will cause the bad pulmonary hemorrhage. It was a difficult decision because treatment by itself can increase the risk of the pulmonary hemorrhage, but I treated that kid with ibuprofen and that PDA was closed and that baby survived, so no more hemorrhage now. But there are reasons and indications to treat PDA before 2 weeks. So do an echo when you feel like it's the right thing to do.
Well, it's basically a clinical decision.
Exactly. It's individually tailored.
Yes, exactly. Thank you very much. You want to say anything, Dr. Dureshawar?
Yes, sir.
We have another. Yes, yes. And then we go to next question by Dr.
Yes,
Alam. Yes, please.
sure, sir. Thank you so much, Sir Hussnain just answered my question, because there is a gray area, as I said, between 7 to 14 days. This is, I'm emphasizing again and again, between 7 to 14 days. Early treatment means, as per literature, I know it's before first week, to be particular, if you talk about Oscar trial, before 72 hours of birth. But what I'm talking about is a gray area between 7 to 10 to 14 days. Thank you so much, Dr. Hussnain, for answering my question.
Thank you very much. Dr. Alam, you have a question. Are you there?
Yes. Assalamu alaikum, sir. Thank you
Yes.
very much. And thank you, rest of colleagues and Hussnain. I was just wondering, is there any latest age? For example, baby is 4 weeks of age and has significant PDA. Would you still go ahead and treat them? Or is there any latest age where you say, oh, no, this baby cannot be treated, especially medically?
Right. So there is nothing that is definitive threshold for not to treat, but with the advancing age, the chances of medical treatment, successful medical treatment, goes down. I personally have treated a baby up to 3-4 weeks, and the only reason I make that decision was because rather than sending the baby to the cath lab, why not you just do a trial of medical treatment? If it fails, it fails. We just should not expect higher success rate at that point. But I haven't tried anybody beyond 4 weeks.
Thank you.
Any other comments? Any other comments from any other seniors?
Dr. Sujad, I have a brief comments on a couple of things.
Yes.
The first
Mr.
comment,
President.
yeah, the first comment
Yes,
I
sir.
have is that we are also part of pivotal trial. It's going on, and we
Okay.
have enrolled a lot of babies here in Nationwide Children's. My comment is about the problem we have with PDA, we don't have a safe and best treatment to close the PDA. I think you have to take the benefit and risk of treating it. As Dr. Junaid also mentioned, sometimes the treatment is actually more harmful than you are thinking. It also causes changes in the prostaglandin balance, and many of those babies, when you give, for example, the stronger medication we used to use, Indomethacin, it used to also compromise the perfusion to the organs. And especially if you have a baby who has, sorry, I have to take this phone call, but I.
Okay, so in the meanwhile, is Dr. Tosif there? Dr. Tosif, you had a question. And the question what is he asking is, what is the youngest gestational age at which PDA stenting has been done in cases of preterm duct-dependent circulation? Then maybe you can answer this question.
So it really depends who is the person. It's a very person-dependent decision. If you are in Memphis and Sham is your cardiologist, he want to just go ahead and do this device closure for whatever gestation. He said he will do it for 24 weeks. Most places don't do that. We usually do at 500 grams, mostly 24 weeks or above.
So, okay, thank you very much. Any other experience on this device closure? Okay, any other comments or any other questions from the floor?
Assalamu alaikum, I'm Dr. Alia.
Yes,
I just
please.
want to add one point. The point is that we are seeing more and more preterm babies nowadays. With advancement in care here at Pakistan, we are gradually moving on to see more smaller size of the babies, and I think this is the time and era in which we can experience these kind of new interventions. I would not say new intervention, but ongoing already across the globe. But we have yet to see the device closure in smaller babies. I just want to know what is the experience of other colleagues and senior, especially from Pakistan.
Any comments from anyone, any seniors?
Can the question repeat, Dr. Siddharth? What is the question?
Yes, Dr. Alia, can you say it again?
So my question is that here in Pakistan, we have yet to see the experience of device closure in such small babies, because all the centers in Pakistan, because with the advancement in the neonatal care, so now we are more able to see smaller gestational age babies and who may have such kind of problems. So just wanted to know what is the current status, if somebody has any experience or any data, especially from
No,
Pakistan.
I think as far as I know, from Pakistan, nobody has the transcutaneous thing, and everybody doing the stapling and open PDA closure if it is requiring. Even the PDA closure is only in the very hi-fi one or two centers like Khan in Karachi or something like that. So it is not available, but of course, as you said, that advancing in neonatal care, maybe it will come, but I don't know. I know many of the cardiologists who are and the pediatric surgeon who are doing the closure of the PDA, but none of them is doing this transcutaneous so far. That's my understanding up till now.
Maybe
you.
anybody
Thank you.
from Pakistan can comment. Yes, Dr. Safdar, you are back.
Yeah, I apologize.
Yes, please. Yeah, please continue.
Professor Jat, can I word please?
Yes,
Dr.
Dr.
Sajid here.
Yes.
Yes, Sajid, yes, please.
Sorry, I was driving and I have just joined a couple of minutes ago, so I must have missed most of the questions. Because I'm doing neonatology and non-interventional peds cardiology with AFIC for the last 9 years since I'm back from UK. So as far as the Piccolo device is concerned, which is used in extreme preterms, usually they are 700 grammars, and all of you know when there's a true premature 26, 27 weeker, that is not our target in this country. So once you've got more babies who are 700-800 grammars, they are being saved, then research, grows. The reason is in Pakistan, we don't have this much survival. That's why still Piccolo device is a theoretical thing. Maybe somebody has done it last week or 2 weeks ago, but it's not being done because the device which is used in bigger babies, that is ADO2 device, that is being used in, alhamdulillah, in Pakistan. People have closed these PDA with devices, but in Pakistan, answer is so far, I think, is not there. Regarding other questions, because in my center where I work, we do echoes on all babies. We have got luxury of this echocardiography. Problem is that in Pakistan, if you look at the scenario, most of the babies, even 32 weekers and 34 weekers, even when some cardiology guy comes and do the echo and there's a large PDA, even that baby is 33, 34 weeker. In my experience, in 8, 9 years, people start closing these ducts. So usually the bigger babies, they have got large PDA for some other reasons as well. There is no need to treat. And usually when we keep on doing echoes, we have seen that in 2, 3 months, they usually close. For preterms, it takes a bit longer. So you have to reduce the feed to 130 ml per kg. Sometimes few parents or the neonatologists, what they do is they keep on increasing the feeds and they're giving a lot of feed. That creates a problem. And sometimes when you give 160, 180 ml of feed, and the problem is that volume is so much that even if you have static diuretics, the diuretics, they fail, they don't work. So in this case, you have to start milk, which is high calorie and low volume. That's why we have introduced Infotrini, which we used to do in UK. So in bigger babies, I'm not saying about premature because it has got a very high sodium and potassium content and phosphate. So the bottom line is that in Pakistan, usually in 9 years, what I've seen that our most of the babies who are 800 grammers or 900 grammars, actually they are IUGR. And even a baby 800 grammars comes and you see in 2-3 days PDA closes, or there's a tiny PDA. It means these babies are the babies who have gone through a very struggling phase in utero, and that's why there's no PDA or very tiny PDA. So what I would advise is that the HSPDA, it's not that every murmur should be treated. It's not that if somebody has done an echo on day 3, 4, sometime our ventilation is not right, oxygenation is not right. There are other common factors. Stick to the basics. And giving Brufen, I have seen that because we don't do much renal functions, and sometimes people do give IV Brufen because that is available in Pakistan. And these babies, their kidneys are knocked out. Even few oral medication that affects as well. So I totally agree with Dr. Junaid that in Pakistan, when we have got limited resources, stick to basics. And if you don't have the echo facility on day-to-day basis, where you can see the difference. So in my practice, when we have started Brufen orally, and I agree with one of the speaker, I forgot the name, that the paracetamol we did use as well, but response is not as great. A number of doses are more, but Ibuprofen that does work, and we have seen that. But how we have seen that? We have done the echo today, and I have given the dose, and next day in the morning, the first time I'm gonna come in the NICU, and what I will do is before even starting the round, I put the probe on the duct and see whether duct is getting smaller or not. So we did see these that effects, but in the babies 28 weeks, 29 weeks, something like that, were struggling on the ventilator. They have got bonding pulses, they've got LALB dilatation, and they have got the features, the clinical feature of HSPD as well, and the features of the echocardiogram. So echo is the gold standard. So combining echo, regular echoes with the clinical, I think this is how it will work and save more babies and save us from the side effects of these medications and over-treating babies. This is my point.
Thank you, Dr. Sajid from Wahakent. Yes, Dr. Safdar.
Yes, so I echo
Sorry.
what Dr. Sajid has mentioned, but I want to add that I want to share my last 2-3 years of experience. I have not treated a baby who was born at 28 weeks plus at birth with PDA, like for any intervention. Because if you look at the data very deeply and closely, the spontaneous closure rate is so high in these bigger babies, and actually treating them, in my experience, does not make sense. We treat babies with PDA, and since this report has come from the AAP, we have all been on the same page that we're not going to treat any baby who is less than 2 weeks. And the reason being is that the ibuprofen, indomethacin, even paracetamol, we don't have ideal treatment in the setting where you already have compromised perfusion due to PDA, especially if you see on echocardiogram reverse end diastolic flow, and in some babies we see that. And if you add on top of it like indomethacin or ibuprofen, you are actually gonna imbalance the whole prostaglandin, um, peripheral perfusion, the balance. So that's why the data also reflects that. And Dr. Junaid actually referred to that. Some of these medications actually are more harmful than beneficial, because at the end of day, closing PDA is not the goal. The goal is to have better outcome. And if the data suggests that, if you treat and you don't treat, you don't have better outcome, so treatment is tilts towards more taking more risk. So that is one point I want to share as my experience. Like, as I said, like we don't treat bigger babies for PDA when, especially if they are not ELBWs. And the second thing is our center is part of pivotal trial. And I think Dr. Khabar Nawaz mentioned about that, and his center is also part of that. And that will be very nice to look at, like, the data after this trial is over, because that's all catheter closure, like they're doing. And they're randomizing very nicely. And they're sending all the echoes to the McNamara group, which is in Iowa, so which actually have done a lot of work on hemodynamic significance of the PDA. So they are all part of that trial, and we will see how the results come out. It might actually tilt the balance. This is my prediction. Like after like a year or two towards catheter closure slowly when people have more confidence and skills and better devices are there. And I want to share anecdotal something. You will be surprised. I had a baby who was like, had a large PDA, and we were waiting and was not closing on its own and was causing all sorts of problems. So we decided to go for cath closure. And the PDA was so large, and when they put the device in the PDA, it actually was so large, it was not holding there. And the cardiologist told me he just held there. He just slowed the blood flow through the PDA for like 30 minutes. He just was standing there, and the PDA closed on its own. And he said some of these PDAs, they are like, spasmic. Look, if you block the flow for some time, actually it starts something which actually, closes on its own. So which was interesting for me, like to share with you. So I think in future we will probably have more information after all these trials are over, and we will have some better solutions to the PD, especially the one who are 23, 24 weekers.
And Sardar, I just shared one slide about what you said, that the spontaneous closure of PDA. If you open that slide and if you can see that even with the 26 weeker, the closure rate is very high, spontaneous closure. So it's a very, very small, population which we are talking about. So in the chat, I put it that slide because I cannot share the slide.
Yeah, it's there,
So you can see. So if
do you see the slide I just shared?
You just shared. Yeah, this is the one. So if you can see that only the 26 weeker babies, you can increase the thing that less than 26 weeker, it's also close 50% closure. So we are also talking about a very small, population of those very small babies. So 26 to 27, as you can see, the blue line, and then 28 to 29, and then so on and so forth. There's almost all closed spontaneously. Just for that discussion that when to close or when not to close, it is very helpful.
Thank you very much, Dr. Junaid Khan, for your excellent slide, and Dr. Safdar for your comments, which were very, very helpful. Can I invite Dr. Khalid Haq for any comments, please? Professor Khalid Haq.
Thanks, Sajad. It's one of the best journal clubs which has happened in your series, and it's very well presented by Dr. Anum and very well monitored by Dr. Hussnain Mirza. And the discussion is excellent. I have enjoyed it very much. Thank you all very much. Thank you.
Thank you very much, sir. And there was a comment from Dr. Ishaq from Peshawar. Are you there, Dr. Ishaq? Yeah, he's saying that one of their doctor, Dr. Sadia Elias, in Lady Reading Hospital, Peshawar, has used Piccolo device for the first time in Pakistan.
Assalamualaikum, sir.
Yes, Dr. Ishaq.
Sir, I was confirming it from Dr. Sadia Elias, who is AP in Lady Reading Hospital, Peshawar. I just confirmed it from her. She's saying that she has done 4 Piccolo device closure of PDA, and the minimum weight was 1.3 kg, and she's actively doing now, and up till now 4 successful device closure through Piccolo device has been done, and I have recently confirmed from her. Thank you, sir.
So she's your local interventional cardiologist.
Yes, sir.
Oh, that's good. Good to know that. Thank you very much.
Thank you, sir.
Yes, Safdar, we can conclude the meeting. Dr. Safdar.
Professor Sajad, can I say something?
Yes, please. Yeah, please. Sorry.
Actually, if you look at the weights, like Professor Sadi, I know her, they have closed at 1.3. So what we need to realize that in the pediatric cardiology is not a neonatal cardiology, and neonatal is not pediatrics. So there is a gray area in between that as well. So what happens is that there are few bigger babies, like even 1.3 or 1.5 or even nearly 2 kilograms, where there's a PDA. So when you compare the surgical ligation as compared to the device closure, then that gray area comes in which there are few cases where you can use the Piccolo device. That's there, I agree with that. But when we are, discussing the stringent criteria for when we have decided that usually this HSPDA is in less than 28 weekers, and I agree with the few respondents. I totally agree with them that even in the 26, 27 weekers, few PDAs they close because it depends upon how much the duct is sensitive to the oxygen, how much strong that muscle is, and what is the genetics of that baby. That few babies are genetically, they have got this component that PDA closes early, even in 27, 28 weeks. And few of them, it doesn't close. It is because of this prostaglandin imbalance, and more what they need it for some other reason to for oxidation point of view to maintain the hemodynamics and the when we are talking about the pulmonary pressures and SVR and PVR. So that's why you need that PDA for a long time in these premature babies, but it doesn't qualify that HSPDA. So the device which they have used, my understanding is that these are different indications. But for particular cases of 700 grams in Pakistan, I don't think so that someone has closed, but maybe someone has closed, but this is my feeling. My last comment is that in Pakistan, the neonatology, if the neonatologists, they have got skills to have the course. It's like in UK, they do 1 year course in which there's a neonatologist with peds cardiology interest, and they have got on-hand echo. If that is combined with the clinical sense, then probably we are picking the right cases and treating them rightly, and we will not be in the area of overuse or the side effects of medications. So in my center, I hardly use these medicines in babies 29, 30, 40 weekers, and I've seen it because I followed them for quite a long time, and their PDS, they close.
I think that's very right, Dr. Sajid. The neonatologists in Pakistan need to have an additional skill, and that's the bedside echo. And then probably that will improve the care of babies, particularly those preterm babies with the PDA. Thank you very much. Yes, Dr. Safdar and Dr. Hussnain, anything else?
Sir, I'm very happy that you gave me the opportunity to see so many people on one forum. Thank you very much.
We'll see you again in October, inshallah, for
Inshallah.
your presentation. Thank you.
Yeah, inshallah.
Yes, and Dr. Safdar, over to you, sir.
Assalamu alaikum, Dr.
Doc-
Sajad. May I say one last comment?
Yes, please, Dr. Naila.
Sir,
Sorry, your voice is muted, I think. Yes, unmute yourself. Yes, that's fine.
Yes, can you hear me?
Yeah, please.
I was just wondering about thinking about the situation in our areas where we don't have bedside echo. We get an echo once, and in a difficult situation where we send the baby to the cardiologist and we get an echo, and in that echo the PDA is not hemodynamically significant. But during the stay in the unit, when we seeing that baby is not fine and is giving the sign symptom of heart failure, we used to treat the baby. So most of my colleagues in Pakistan are facing this challenge that we don't have echo at the moment. What do you suggest the seniors who have access to echo, if they don't have access and they are seeing that clinically baby is not fine? Because I myself find myself on one morning round that although the PDS was not significant, but this baby seems in heart failure at the moment, I should treat. What should I do? Just give for me and the rest of the colleagues, give some suggestion.
Okay. Dr. Sajad, you want me to
Yes,
say
please,
something?
please. Yeah, please.
Thank you. So, Dr. Naila, I don't know what kind of equipment is available, but do you guys have point of care ultrasound available in the NICUs?
Yes, we do, but it's not for all the NICUs. In my center, I do have a point of care ultrasound. Even we have this echo device, although we are not using that frequently. For echo, we depend on our cardiologist, but it's for all of rest of my colleagues who are doing neonatology. I just want to get some advice for all of us.
So I think it will be very dangerous to make that decision based on the clinical perception rather than without confirming whether the PDA is really a problem or not. I can share an experience with you, and it happened when years ago when I was working with Dr. Sajjad in England. There we had a 23-week baby whose blood pressure was kind of low, resistant hypotension, and the team I was on with, they keep pushing the fluids, trying to maintain that blood pressure, and that blood pressure will improve for a few hours, and then it will go down again to get another fluid bolus. By the morning, that kid was really, really stuck on high ventilator settings, and still the blood pressure was low until somebody showed up in the morning who used to do bedside echoes, and he looked at that huge PDA. And that was the reason for low blood pressure. Rather than keep pushing the fluids, that kid should have been on the dopamine or dobutamine. So the clinical decision based on assumption is not safe. So if there is a point of care ultrasound device available, usually they are not very expensive either. It's always a good idea to put the probe on and get some idea yourself.
You are
Point.
talking
Thank you,
about
Dr. Hasnan.
Can I answer?
You are
Yes, go ahead,
talking
Dr.
about
Junaid.
you are talking about Hasnan 2025. Okay. When I do my fellowship or residency, we don't have this point of care ultrasound. We have only cardiologists. And 2 a.m. we are situation we have. So the clinical judgment still has a lot of value. Okay. We have to, that's why I always said in sepsis, in PPHN, in PDA, your clinical judgment has a lot of value. Now, the hypotension is not that in your baby, in your case, that you give the fluids. You have to see other signs symptoms. What is the perfusion? How is the urine output? So everything together you will see. So I think the clinical perception for Nyla is still a valid if you can see the carbon dioxide retention, if you can do an X-ray to see the pulmonary edema, if you can do the periductal and the postductal to see if there are any element of PPHN. So all these, and of course the blood pressure, fold in blood pressure will also helps you. So I think if you don't have these things, rely on these things and then treat accordingly. This is my thing because I know that in Pakistan, many centers has no echocardiograph.
Right. And you know,
Dr. Sajjad, can I answer?
So
yes, please. Let Hasnan finish, and then Dr.
I
Sajjad, you
want to
can
say
say.
clinical skills are superb in Pakistan. My mentor in Pakistan put his stethoscope on a child's chest and said, absent pulmonary valve syndrome. And I said, how can you make that kind of diagnosis without doing the echo? And he said, it's a musical murmur. I heard that murmur all day. I still don't know how to call it a musical murmur, but he was able to make that diagnosis in 60 seconds. So clinical skills are catch-22, double-edged sword. In the right hands, perfect. In my hands, not so much.
No, it's
Okay.
no.
Dr. Sajjad, yes. Sorry, Dr.
Okay,
Junaid.
so
Apologies.
so because the reason is that I worked in UK and I'm working in Pakistan, so I think I can just comment better on this picture. My answer to Naila is that yes, clinical sense matters. It's very important. Approach is that if you've got a baby 26, 27, 8 week, that's a different story. If you're coming a baby even 1 kg, 1.23 kg, 30, 32 weeks, if there is a suspicion, even on clinical grounds, that there is a PDA on clinical grounds, you don't have the echo. The thing is, you have to restrict the fluids. That's very important. And you have to start feeds because feed has got more calories than the sugars. Because when we give 10% dextrose in Pakistan to babies, 10% dextrose, every meal gives 0.38 kilocalories. Otherwise, if you give a milk, 1 ml gives 0.68 calories for A1 term formula, and preterm formula is giving higher. So my concept in NICU is I aggressively start feed early because that gives proteins, fats, carbohydrates, minerals, sort of genetic factors, so many things, list goes on. So once you restrict the fluid, number one, most of the babies, they improve, number one. Number two, if they are not, then you have to give a tiny dose of diuretics, and they are very sensitive, they respond to that. Problem with the higher diuretic is the kidneys are very premature. And when you diurese the kidneys by force, that has got an injurious effect with furosemide. So what we do is that we go clinical basis, for example, if I don't have echo, gel exposed, I'll go on clinical grounds, then I will restrict the fluids to 120, 130 ml. If not, I will just give a tiny dose, 0.5 mg per kg twice daily, and let's see the effect in 48 hours. Most of the time, you will save these babies. But this category of the babies where they are not falling under 28 weeks, giving ibuprofen will be riskier, not indicated, has got so many things, and in the busy shifts, nobody will bother about the renal function, urine output. That will be because of the ibuprofen. So in our country, that's the one thing. Other thing is that few people did bought these machines like IQ something that's in America. It's available a probe. You put the probe. Sometimes just putting the probe and looking at a bigger PDA does not mean that big PDA is significant and you have to close it, because that is there for a purpose for that baby to survive. So again, if you have got the point of care ultrasound, unless and until you have done a training proper, just putting a probe and treating these babies will be again problematic unless and until you save the video, you share the data with your cardiology colleagues, give them the full clinical input. That might be a better option that they will give you the answer. This is what I am doing over here. So this is my point in this case, the how to treat these PDAs.
Thank you very much, Dr. Sajid. Any other
Thank you, Dr.
comments?
Sajid. This is really helpful because I just want to get an idea for all of those who don't have to this echo, and I think now people are clear that treating again and again for PDA is causing problem for the baby. I think you have given a better approach that restrict the fluid and build up the calories with well. And a smaller dose, that is something I have seen in multiple centers that they treat it with first give trial of paracetamol. Okay, it's not working, give ibuprofen. Okay, it's not working. So this is something I think most of people have learned, that they should not give this hit and trial again and again.
Thank you very much, Dr. Naila. I think treating the PDA in preterm infants is a hot topic, and still there are many controversies whether to treat or not to treat. And if you have to treat, when to treat and how to treat. And this debate will continue. I think we had a very useful session today, a great presentation by Dr. Anum Shah and supervised by Dr. Hussnain Mirza. Thank you very much, Anum and Dr. Hussnain. We're so
Thank you,
grateful to
Dr.
you for your hard work. I know you have been working for the last 3-4 months
Thank you.
to
Thank you
come to
so
this
much.
very good presentation. Yes, very good. And I encourage other fellows from Pakistan and other places to participate. Next month we have Dr. Pirzada. She is a neonatal fellow in Canada, and she will be giving a presentation. Any final comments from anybody? And otherwise, Dr. Safdar can close the meeting.
No, this was actually one of the best sessions we have done on Journal Club. And I really appreciate Hasnan and also Dr. Anam for doing wonderful job. And thank you everyone joining. And I think we should continue this activity. We should be more innovative moving forward, like how to like bring different ideas, have more interest of people in it. So I think any thoughts, any suggestions are most welcome. It's not like we are all together. So if you have any new idea, just share with us. We will try to accommodate. And thank you all
Indeed.
once again.
Indeed.
Sure.
Thank you very much. And
Thank
next
you.
month it will be Dr. Saima Pirzada, supervised by Professor Zulfikar Bhutta. And I think it will be a
Okay.
topic related to perinatal epidemiology. Probably we will have a broader and bigger picture of what is happening in LMIC and in Pakistan, and how we can address the newborn care at a higher and a bigger level. Thank you very much, everybody.
Thank you.
Enjoyed
Thank
it
you
a
very
lot
much.
and learned a lot. Thank you. Shukran.
Thank
Assalamu
you.
alaikum. Assalamu alaikum.
Walaikum assalam.
Hafiz.
Allah Hafiz.
Thank you, Hussnain.